I'm going to talk a lot about the interface of aging with psychiatry. So, as Chris said, I practice geriatric psychiatry, and it is not a new subspecialty in psychiatry, but it's becoming increasingly relevant as the population ages. I'm going to turn this back on, and we'll see what happens. The first part is going to talk about general concepts in geriatric psychiatry, and in the second part we'll address specifically substance use in older adults. Just as by way of introduction and to sort of frame the conversation, I wanted to mention a couple of things. Like I said, the population of the United States is aging as the baby boom cohort ages, and as life expectancy increases. We're seeing a rise not in just older adults, whom we define demographically as 65 and older. I'm sorry, that's not me. That's the Census Bureau. We're also seeing a rise in the population of what researchers call the oldest old, those 85 and older. By 2030, the population of those older adults, oldest old, 85 and older, will be larger, multiple times larger than the population 65 and older of 1900. So this is going to be a huge demographic shift, and you might hear talk of the sandwich generation, those working adults who are taking care of children at home or dependents 20 and under, as well as aging parents. So they're caught between two generations of dependents. Well, now the ratio is about one working adult for every two dependents, but it's going to rise, and it's going to rise in the next 30 years, so that sandwich generation is increasingly sandwiched. And so for that reason, assessing and managing psychiatric issues in older adults is going to become increasingly important. Reimbursement is probably not going to rise, but addressing the problem is going to become increasingly important. The other thing that I want to say is, for one of the reasons that I really love geriatric psychiatry is it's a unique population, and everybody's the same age inside all the time. Regardless of what your chronological age is, you're the same person. But as you age, you experience changes. And the changes that you experience when you're leaving college or starting a job or getting married or having children, those changes you can anticipate and look forward to and prepare for. A lot of people don't anticipate, look forward to, or even prepare for the changes associated with aging. And aging is, in some ways, a series of loss. There's a loss of physical function, there's a loss of loved ones, there's a loss of societal roles. At the same time, and I always express this to patients, aging is the time of fulfillment. Older age is the time of fulfillment. You've done your striving, you've done the plowing and the planting and the cultivating. Now is the time of harvest. Most of my patients want to hit me when I say that, but I really do believe that aging is the time of fulfillment, and so supporting older adults in this time, I think, is really important, and that's why I get excited about the topic. So without further ado, there's going to be a question and answer portion at the end of this talk and at the end of the second part of the talk. And I'll remind you when the time comes, just leave a question. When you have a question, just ask it into the microphone that's provided for the taping. So let me just jump right in. There are physiologic changes associated with aging. Skin elasticity declines. Both chest girth and abdominal girth grow. Your ears get longer. Your noses get longer. It's real. It's not just you. That's really happening. But there are also psychological changes associated with aging. Just as kidneys age, just as lungs and hearts age, the brain ages as well. And the functions of the brain change as a factor, as a function of aging. So there are normal psychological changes affecting memory, cognition, mood, sleep, sexuality, just as part of normal aging. I'll talk about abnormal psychological features of aging after I just introduce what's normal in aging. Let me start with memory. In normal aging, memory is slowed but intact. I can't tell you how often, either in my office or at a family function or a cocktail party, people are always asking me, do I have Alzheimer's? Because I can't remember, I was talking and I could not remember that actress's name. And I said, well, did you remember it on the way home? And they said, yeah, Doris Day. I said, that's not Alzheimer's. That might be old timers. That might be sometimers, because it only happens sometimes. But it's not Alzheimer's. That's normal aging. It's in the memory bank. The retrieval is delayed. The recall is slower, but memory is intact. It's in there. It just takes longer to get out. That's normal feature of aging. There are other thought processes besides memory, though, that are affected in aging. Those are what we call cognitive processes, thought processes. Cognition, as a feature of normal aging, declines over time. Verbal fluency and language is preserved intact pretty much throughout the lifespan in normal aging. And even in certain types of dementia, like Alzheimer's dementia, language is preserved until relatively late in the course of the illness. Number fluency does decline beginning at age 40, okay? Right about the time that your body stops preferentially producing muscle and starts preferentially producing fat, your brain starts to lose the ability to remember sequences of numbers or do complex arithmetic. And it continues to decline from age 40 on into the 70s, so that by the mid-70s to mid-80s, as a feature of normal aging, normal older adults have difficulty with number fluency. Reasoning ability declines less sharply, but by the time you're, again, in your mid-70s to mid-80s, you begin to have difficulty learning new information or applying reasoning and cognitive functions, those frontal lobe functions. So that by the mid-80s, just as a feature of normal aging, most people are going to require assistance for complex planning like financial planning or medical decisions, okay? Individual decline before age 60 is generally not normal, so then you're looking at some sort of dementiform process or cognitive process. In terms of mood, and it's important to recognize that older adults who might never have had a mood disorder throughout their earlier life or their adulthood can develop some disordered mood states. Because of brain changes, but also because of major life adjustments. The loss of or decline of roles. If you're a homemaker and the kids have moved out, you can lose that role. If you're an older adult male and you're retired, or in this economy forced into early retirement, that's a huge life adjustment. That is a loss, that's a bereavement. And there are normal emotional responses to those bereavements. Grief and worry are not pathological, and we don't typically medicate those things. We do address them and support them. Memory, sleep, and appetite can be affected, okay? People with anxiety or grief or depression can have difficulty with concentration. Their sleep can be disturbed. Their appetite can be affected as well. Depressed patients have difficulty encoding new information. Again, memory might be intact, but learning new information can be impaired in depression. Sleep architecture changes as a feature of age. In general, older adults have less REM latency, and their REM sleep is it's not as long, and it's not as consolidated. Okay, they sleep less at night. Their sleep is less consolidated, and they tend to take cat naps or doze during the day. This is a normal sleep pattern in aging, but it does change as circadian rhythms change. In the elderly, though, more than half of non-institutionalized elders do report chronic sleep difficulties. And so when you're doing an assessment of an older adult with a sleep complaint, you have to sort of differentiate. Is this just a normal age-related pattern? Is there another process like sleep apnea going on? Are medications affecting sleep? So you really have to kind of do a lot of detective work in assessing sleep disorders in the elderly. In terms of sexuality, the ARP study shows that 75 to 86% of middle-aged and older adults are still sexually active, and interest and activity really depend on the individual's physical health and access to partners. What they have shown is that among older adults, regular exercisers have the greater sexual satisfaction. Can you please stop stretching back there? Okay, thank you. So common concerns, like I've addressed briefly, in older adults are cognitive impairment, or even disabling cognitive impairment, which we refer to as dementia. Delirium, which affects not just older adults, but can affect them disproportionately compared to the rest of the population. Polypharmacy, the use of multiple medications, which is really a common concern in gerontology across medical specialties. depression, anxiety, elder mistreatment and abuse, as well as substance use disorders, which I'll address at length in the next portion of the session. Let's talk about dementia. When clinicians are talking about dementia, we're talking about cognitive impairment that is chronic, it's not going away, that is progressive, it's going to be degenerative, it's going to decline. Cognitive impairment that's disabling. Okay? Typically in psychiatry, the definition of a disorder is something that impairs daily functioning, and that's our definition for dementia. And it's not just memory impairment. There are other cognitive domains that are affected. Language can be affected. Procedural memory, the ability to ride a bicycle or button a blouse, can be affected. Agnosia, the ability to recognize an object in space without seeing it in spite of normal sensory function. Okay? And executive function, and I'll talk about executive function, but it's really just those frontal lobe functions that we talk about. Those can be impaired to a degree that daily functioning is impaired, and when that happens, that's dementia. So let's talk about some definitions. I gave you the great jargon that allows me to make a living, but I wanted to define it for you in case you ever come across these terms. Aphasia is a language deficit, and you see in stroke patients sometimes while their other cognitive functions may be intact, if they have a lesion in a language center of the brain, they have what can be called an expressive aphasia. They are trying to communicate, but it's not coming out. Or they can have a receptive aphasia. Their outward communication is not affected, but their ability to understand language can be impaired. In dementia, you can see this language impairment, and you can see, especially at later stages of Alzheimer's dementia, or really early on and at the onset of frontotemporal dementia, you can see deficits in language. Apraxia is the impaired ability to carry out motor activity despite intact motor function. So a Parkinson's patient may have apraxia due to the neurologic condition. A multiple sclerosis patient, the same thing. A dementia patient really doesn't have a neuron or motor problem or muscle problem. They have a cognitive problem. It's the central processing unit that's the problem. Agnosia is the failure to recognize or identify objects despite intact sensory function. It's always important when you're doing a cognitive assessment to make sure that your subject has their glasses, their hearing aids, and the hearing aids are working. But when you have intact sensory function and are unable to recognize objects, that can be a feature of dementia. And then executive function. So the slide for executive function is malfunctioning. But when I talk about executive function, I'm talking about the functions that executives do: reasoning, planning, judging, the ability to conceive a plan, execute the plan in steps, evaluate the outcome, and make refinements. All of those complex processes that we do to manage finances or to get from home to here, all that falls under the umbrella of executive function, and that can be impaired in dementia. And that starts to speak toward questions of decisional capacity, as the physicians call it, or competency, as the law describes it. So let's talk about the epidemiology of dementia. So this is a graph of older adults with moderate or severe memory impairment. And I'm sorry, this is over 10 years old, but when I've done a subsequent search, I've never found anything that's more up to date, but you get the idea. You can see that as older adults age, and as they get to that old cohort of 85 and over, up to a third of older adults in that age group will have significant memory impairment, moderate to severe memory impairment, so mild cognitive impairment to dementia, okay? So it is an age-related phenomenon. There are a lot of different types of dementia. Alzheimer's dementia is the most common type. It accounts for about 20% of all dementias. There's also vascular dementia, which is a close second in our country because of our risk factors. The natural course of Alzheimer's dementia, it used to be that from the age of diagnosis to death was about 7 years. Now, not because of anything that we've been able to do in addressing Alzheimer's, but because of the things we've been able to do in sort of keeping the organism alive, it's more variable than that. But over the course of time, you can see the beginning of symptoms that can affect functioning, and then from there, you get a loss of independence. So that executive function is becoming impaired enough that somebody needs to monitor and supervise the adult and keep them safe. You can get behavioral disturbance, you can get agitation, you can get paranoia, you can get depression, anxiety, physical aggression. And then you start to lose the ability to walk independently. You can lose the language. You can begin to lose the ability to feed yourself. You can begin to lose the ability to swallow. Then you're talking about nursing home placement and death. So you'll often get people who are non-ambulatory, so they're in bed or they're in the wheelchair a lot, they're susceptible to skin breakdown. Also, they're nutritionally compromised, so they're more susceptible to skin breakdown. They're susceptible to aspiration pneumonia. So those are the things that make Alzheimer's dementia or any dementia a life-limiting illness. In fact, in the later stages of dementia, it's a hospice-eligible diagnosis. Dementia is one type of cognitive impairment. Again, it's chronic and progressive cognitive impairment. The other very common type of cognitive impairment in older adults is delirium. Delirium is an acute, not chronic, change in cognition and attention, characterized by waxing and waning consciousness. Okay, this is really an underlying medical condition. So differentiating between dementia and delirium is very important for the clinician. Can a patient with dementia also be delirious? Yes. Okay. Is a delirious patient bound to be demented? No, but it can be a significant predictor of future cognitive impairment. Delirium is the most common cognitive disorder in hospitalized elderly. It's also seen in about 50% of all surgery patients regardless of age. So it doesn't just affect older adults, but it is very common in older adults. It is associated with severe medical illness. There is a poor functional outcome, so it does increase risk for subsequent nursing home placement and loss of function and independence. Behavioral symptoms can be distressing and disrupt medical care. So hallucinations can obviously be very distressing to family members and loved ones who are visiting the elder in the hospital. They can develop agitation and pull at lines or be combative with staff and so interfere with care activities. The clinical features of delirium include abnormal attention. So a dementia patient, their attention can be impaired, but they can attend and they can listen to what you're saying and they can kind of focus more than a delirium patient can. They can have cognitive deficits. If you give a brief memory exam to a delirium patient and a dementia patient, you'll get pretty much the same deficits that you see. Again, problems with delusions, hallucinations, agitation, physical aggression. Okay. And you can get what's called a sort of depressed delirium or a delirium with psychomotor retardation. Instead of a lot of agitation, they might be very passive and just slowed globally. You get sleep-wake changes. The hallmark of dementia, of delirium, is waxing and waning consciousness or attention. If somebody's sort of nodding out or fading in and out of consciousness, that's really the hallmark of delirium. Delirium can be caused by an underlying medical condition, either an electrolyte imbalance or the result of an infectious process, and it's very often caused by medications. Certainly the anticholinergic medications like narcotics or antihistamines, anesthesia is a very common cause of delirium, but also other medicines we use like antispasmodics, nausea medicines, cardiovascular drugs like digoxin. If you have a delirious patient who's on digoxin, you want to check a digoxin level because they can get drug toxicity. Narcotics, like I said, but also some non-steroidal anti-inflammatory drugs. So there have been some case reports of patients who've been on IV indomethacin who have this persistent hallucination of a luminous mist kind of entering their room. So there's a specific area of the brain that's affected in patients receiving IV indomethacin. So medications can have bizarre side effects. Even some antibiotics can cause delirium. Levaquin is a common cause of delirium. That's a very common antibiotic for the treatment of pneumonia. Also, H2 blockers like famotidine, cimetidine, Pepcid, and other medicines like that, Zantac. Anti-epileptic drugs, anti-seizure drugs like Depakote, and steroids. Steroids are common causes of delirium and mania and psychosis, especially in older adults. That brings me to the subject of polypharmacy. Now, the clinical definition of polypharmacy is the simultaneous use of multiple medications. It's actually 10 or more medications sort of are a clinical threshold for polypharmacy. Or prescribing more medication than clinically appropriate, either higher doses or a larger number of medications or a more frequent scheduling of meds than is clinically appropriate. Elderly patients, studies show, typically are using 3.1 to 7.9 drugs simultaneously. I would love it if my elder patients were only on 7.9 drugs. They can be on 11 drugs, 17 drugs, 20 drugs, 22 drugs. Including supplements and over-the-counter medications, but those are not benign combinations all the time. Another common feature of older adult psychiatry is late life depression. Depression is actually less frequent in older age than at earlier stages of life. And while we're not entirely sure why, it's posited that resiliency is something that people develop as a feature of aging, and optimism. There's actually recent research that shows that the area of the brain that assesses risk is actually beginning to be impaired as a feature of normal aging. So this protection against depression in older adults might be a form of cognitive impairment. But for whatever reason, late life depression is less frequent, but many older adults have at least some symptoms of depression. You know, psychiatry is a very criteria-driven field. So you have to have a certain level or a certain number of symptoms. And while an older adult might have sleep disturbance or down mood or sad mood, they might not have some of the other features that define clinical depression, but they still have depressive symptoms that need to be addressed. Okay? And again, while late life depression may be less common, older adults can have depression even if they've never been depressed before. Because again, there's a feature of brain aging that's associated with late life depression. And older adults who have physical or cognitive impairments are more likely to become depressed and are more vulnerable to biological causes of depression, things like low thyroid function or low testosterone. These are common causes, clinical causes of depression in older adults. But also there's a phenomenon like there's vascular dementia. There's also vascular depression. As the body ages, the arteries age as well. And when the large arteries become occluded in the heart, you can have a heart attack. When the large arteries become occluded in the brain, you can have a stroke. When the microscopic arteries in the brain become occluded, you begin to get tiny pinpoints of scar tissue in the brain. 20 or 30 of these, or 150, 200 of these, your brain doesn't even know the difference. But as they begin to accumulate, you can have deficits in those areas, including the mood regulating centers. So you can have a vascular depression. You can also, if there is damage in the cognitive centers, you can have vascular dementia. And again, dementiform illness and depression can often go hand in hand. In terms of anxiety, late onset anxiety is perhaps more common than previously thought, although it's not more common than in the younger adult generation and than in younger generations. Anxiety disorders are pretty much stable across the life cohort. Older adults aren't necessarily more anxious than younger adults, but it's probably more common than we realize. And again, anxiety in itself can be only a symptom of the depression, so that when you treat the underlying depression, the anxiety gets better as well. What are some preventive measures? So when we're trying to address these late life psychiatric concerns, the first thing you want to do is stay ahead of it and prevent it. People are always asking me, do I need to do Sudoku? Do I need to do Sudoku? Do you like Sudoku? If you like Sudoku, go ahead and do it. If you don't, figure out something else. But the preventive measures, just like for any health condition, you want to get proper sleep, proper diet, proper exercise. Sudoku is plus or minus in terms of its cognitive protective benefit. What is protective is lifelong learning. Okay? For a couple of reasons. When you are learning throughout the lifespan, you're sort of pruning your neural connections all the time. So you're keeping the brain active. The brain is not a muscle, but it's similar to exercise. If you keep it active, it's going to stay active longer. That just makes sense. The other thing, though, is you get more functional reserve. A professor with Alzheimer's dementia usually does a little bit better functionally than a street sweeper with Alzheimer's dementia because they have a lot of cognitive functional reserve. Okay? It doesn't mean that they're not affected by dementia, they're just less severely affected. And socialization is very important in older adults. And I can't stress this really enough because think about all the ways in which socialization is limited in older age. If you're not working anymore, if your friends and family members are dead or have moved away, if you are physically limited by pain or the inability to drive, then your world is becoming smaller and smaller. So to say, oh, socialization is a great preventive measure is not enough because we really have to focus on strategies to keep older adults engaged in the community. Dan Blazer, one of the prominent geriatric psychiatrists in the field today, states that on balance, older adults are more healthy and happy if they remain active in their later years rather than disengage from the social environment. Again, that also provides lifelong learning. The other thing is, if you're going out and talking to people and doing things and exposed to that novelty, your brain has to process the new information. Okay? So keeping people socialized, I always tell my older adults, everybody needs, of course, to be safe, they need to be clean, they need to get their medicines, they need to be fed, but they need something meaningful to do and somebody to talk to. And I always ask, do you have something meaningful to do and somebody to talk to? And if they don't, we've got to get them something and somebody. I'm going to talk a little bit about the pharmacologic treatment of geriatric psychiatric conditions. I took out a series of slides about chemical transmitters and chemical signals, but basically the broad brushstrokes are that the medications that we use to treat mood symptoms or behavioral symptoms in psychiatry affect the levels of chemical transmitters, the levels or the potency of chemical messengers in the brain. Okay? We call them neurotransmitters. When we're talking about a younger adult, we are just going to start them on a medicine. I had a professor who would say, you know, when you have a psychiatric illness in an adult, you give them medicine and you keep increasing the dose until they either get better or they get side effects. Well, that's okay if you're younger, but older adults, because of physiologic changes in metabolism, their liver's not making the enzymes that it made when they were 20, the kidneys aren't functioning in the same way. So because they don't metabolize and clear the drugs as quickly, that has to be a consideration for older adults. Also, when you take a medication, it's distributed throughout your body. You can take a heart medicine, but it goes everywhere. Okay? You can take an eye medicine, but it goes everywhere. And a lot of the distribution and storage of the medicine in the body depends on total body volume, the amount of water in the body, the amount of fat in the body. And as we'll talk about later in the substance use disorder section, as we age, like I said, we get more fat and we get less muscle and we generally get less total body volume and less total body water. So that affects the storage of these drugs, that affects the amount of drugs that are in the blood serum. Okay? So you're getting a built-in dose adjustment just by being older. So for the geriatric psychiatrist, considerations in the treatment of depression or the treatment of agitation or the treatment of psychosis has to be modulated by certainly the effectiveness of the drug. We don't want to give a medicine that doesn't work, but also by safety in terms of the dose, the potential side effects, the interactions with other drugs. You try to choose a drug that's not going to have a lot of interactions or affect the metabolism of other drugs and therefore affect the serum concentrations of those drugs. And the comorbid medical conditions, because every medication has side effects and every medication has potential toxicities. So a medication that might increase either blood sugar or serum cholesterol or affect thyroid function or kidney function has to be considered. Okay? And you also want to talk about compliance. So who's going to make sure that this person is getting the right amount of medicine the right number of times a day? Can the person themselves do it? Or due to cognitive impairment, do they need some supervision or administration, you know, and oversight of the medicine? Do they need to make sure that somebody is giving them the medicine? And you also have to think about cost, because older adults generally tend to be on fixed incomes and medications are quite expensive. And even with the Medicare supplement, there's still a gap, okay? And people aren't going to take a medicine if they can't pay for it. And we know that cost does affect compliance. So we have to be cognizant of that. And when we need to do a prior authorization or get a patient assistance program involved, then we need to be able to do that. I want to talk about the treatment of dementia as well, because in terms of the psychopharmacology of dementia, we do have some medications available. They're called the cognitive enhancers, and they typically are cholinesterase inhibitors like donepezil, which goes by the brand name Aricept, or rivastigmine, Exelon, as well as an MDA receptor antagonist, memantine or Namenda. So we have a limited number of medications. And their use and their effectiveness is actually controversial for a couple of reasons. These medicines don't stop dementia. They don't reverse dementia. They seem to slow the decline related to dementia in some patients, we think. How does that sound? Does that give you confidence? First of all, it's hard to tell when something isn't happening. It's kind of like, one of those signs outside the trailer park, 3 days without a tornado. It's kind of like, oh, 3 more days without forgetting who your grandchild is. It's hard to tell when something's not happening. And the problem is older patients will be started on these medicines and they seem to be doing okay, and the family's like, well, we don't think it's really working, and they stop it. And then there's further decline and they think, oh, well, maybe it did work a little after all. Can we start again? Well, you can, but you're not getting back to where you were. And again, it slows the decline. I want to tick back, if I can, to this slide. So again, we see this progressive decline in Alzheimer's dementia. Now, vascular dementia, because if you think of it as a series of microscopic strokes, which are acute events, instead of getting this gentle, graceful slope and this almost insidious, almost imperceptible decline in function over time, with vascular dementia, you get something that looks more like this. You get stair-stepping. It's like, March 2nd, grandma suddenly forgot what her address was. December 31st, mom couldn't find the checkbook. So you can start to see that progressive stair-stepping in vascular dementia. That's more a feature of vascular dementia, whereas with Alzheimer's dementia, it's more like a gentle slope. Both for vascular dementia and Alzheimer's dementia, these cognitive enhancers have been found to be somewhat useful. For frontotemporal dementia, not at all. For Parkinson's-related dementia, Lewy body dementia, they can be useful. But again, what you're getting is without donepezil or without memantine, what you get is a slope like this. With Aricept, with donepezil, you get a slope like this. And about here, you can add Namenda and it'll flatten out a little bit more, but the trend is still downward. So what does it get you? Well, it doesn't affect mortality. It doesn't push this off, so it doesn't extend life. So at the end of the illness, at time of death, you're at a relatively higher functional level, if it works. So it preserves function. Now, it's controversial because, again, the benefit is modest and equivocal. The American College of Physicians, the professional organization for internists, internal medicine, doesn't even recommend these cognitive enhancers because the evidence for it isn't compelling. The benefits have not been clearly and compellingly demonstrated to outweigh the potential risks or side effects. Common side effects for the cholinesterase inhibitors like donepezil are stomach upset, including diarrhea or bloating, rarely vomiting, nausea. So that's not pleasant. My patients often get headaches with it. Memantine is somewhat more benign. But you can get side effects that are sometimes intolerable. A lot of times demented elders can't stay on these medicines because they can't take the side effects. A lot of times the family say, look, they're already on 17 medicines. I don't want to add another one that might not even help or work. The neurologists typically say, I forget what the organization is, but they say, if you're diagnosed with Alzheimer's dementia, then you should be on donepezil. And the geriatric psychiatrists in typical fashion are kind of like, well, it depends. Sometimes yes and sometimes no. For me, I'm going to recommend it to someone who's in the early stages of dementia, who's still very high functioning to try and preserve function for as long as possible, or for a demented elder at any stage with some type of behavioral disturbance like agitation, because they have been demonstrated to be beneficial in reducing agitation in demented elders. But I always give this little mini lecture to the families to say it's really an individual choice. And there are reasons to do it, there are reasons not to do it. So that brings me to the 4 pillars of dementia care. The first pillar, the first essential support of what we do for dementia patients is we try to treat the disease, and that's what those cognitive enhancers are for, to try and slow the progression of the illness. Then we treat the associated symptoms. If there's depression or anxiety, we address that with antidepressant medication, but we're very mindful, again, of potential side effects. You know, for an anxious younger patient, a benzodiazepine like Ativan or Valium or Klonopin can be very useful. For an older adult, it can worsen cognitive impairment and increase your risk of falls. So I try to avoid those medicines in an older adult, and I have to think of what else I can use. You can get paranoia, like I said, you can get hallucinations, you can get agitation, you can get psychosis, and in those demented elders, we use antipsychotic medications, which do have side effects and they do have potential risks. We also use antipsychotics in the treatment of agitation in demented elders. Now, this is important because they're not anti-agitation medicines, they're antipsychotics, but they're very useful because of their sedative effects in the management of agitation. The problem is there is an FDA black box warning against the use of antipsychotics to treat agitation in demented elders because there is a risk of, an increased risk of sudden cardiac death in demented elders who are on these medicines. And this allows me a chance, an opportunity to give another mini lecture to my patients and family members. First of all, this black box warning applies mainly to the newer atypical antipsychotics who still have a patent and are still very expensive. The older typical antipsychotics, some of which have an even more severe chance of causing these problems, they don't have that warning. The FDA is not so interested in them. Secondly, the FDA has not come out with any helpful alternative suggestions for using these medicines. The third thing I tell people is, if you have a demented elder who's not on this medicine, their risk of sudden cardiac death is 1.6 in 10,000. If you start them on one of these medicines, their risk does increase to 3 in 10,000. It's still quite a tiny risk. If you really crank the dose, because it's dose dependent, it jumps up to 3.3 in 10,000. So what are the risks and what are the benefits? Am I going to put a demented patient with cardiac conduction abnormalities who comes to me with a sick heart, am I going to put them on this medicine? Not if I can help it. But if I can get away with the lowest possible dose, and it means the difference between them being agitated and suffering and potentially violent towards family members or loved ones, and being behaviorally stabilized enough to be placed on a memory unit in a supported environment, or even to be back home and have the family feel safe and confident that they can care for them, I think the benefits outweigh the risks. Okay? So that's sort of one of the features of treating the associated symptoms of dementia. The fourth essential pillar of dementia is supporting the patient, making sure, again, that those basic human needs are met, and making sure that the patient has something meaningful to do and somebody to talk to. There's all sorts of different ways to do that. I find in general that older adults, regardless of what their medical or psychiatric conditions are, they do best in the community integrated into a stable and supportive family. In general, home is best when that is possible. Well, it's not always possible in a post-agrarian society to support that. And so we have assisted living facilities, we have memory units, we have adult day programs. I hate the term adult daycare, but we have adult day programs. We have visiting home health programs. We have all sorts of supports available to make sure that that individual's quality of life and human dignity are preserved. And that's an essential support, a pillar of dementia care. And the fourth essential element of dementia care, I'm just checking to see there are 4, okay. The fourth pillar of dementia care is supporting the caregiver. And I tell people, you know, if this placement option, because I'm talking about patients that I'm stabilizing on our geriatric psychiatry unit when I'm having a family meeting, I'll say, you know, if it's a great deal for mom and a bad deal for you, or if it's a great deal for wifey but a bad deal for you, then it's no deal. Because it's just as important to support the caregiver. In gerontology, the unit of care is the patient and the family. And their safety and their quality of life and their well-being are just as important. Okay? I want to talk briefly about elder mistreatment and give a general overview, because I think this is a field in terms of research that's really still in its infancy, but it's a growing concern. And you might have seen that the son of Brooke Astor, who's now quite advanced in years himself, has just been sent to prison for financial exploitation and mistreatment of Brooke Astor, who is one of the wealthiest women in the world, who was, you know, sleeping on a urine-soaked mattress. Okay, so that is a very graphic depiction of the phenomenon of elder mistreatment in this country, elder mistreatment is a term, a broad umbrella term, that describes a variety of conditions. It's poorly understood because it's still in the embryonic stage of research. The definitions of elder mistreatment vary from state to state and from study to study. So it's hard to get aggregate data because we're comparing apples and oranges sometimes based on the data sources. And theories of elder mistreatment, because we're talking about physical abuse, we're talking about emotional abuse, we're talking about neglect, we're talking about self-neglect, a self-neglecting elder, okay, a hoarding elder who's not attending to hygiene. And we're talking about financial exploitation, which is a totally different sphere, but still under the umbrella of elder mistreatment. The interventions are practically based in terms of treatment and prevention. In terms of the role of the clinician, and this doesn't fall exclusively to geriatric psychiatrists, this is anyone who has clinical interface with the patient, including internists, neurologists, social workers, nurses, it's important to understand that it's out there and what the risk factors are, be aware of possible clues, and perform a systematic assessment of a patient's functional and cognitive status. We conceptualize elder mistreatment as a geriatric syndrome, so it's not a specific diagnosis. It's really a series of symptoms that's in search of a diagnosis. But there are other geriatric syndromes. We talked about polypharmacy. Falls are another geriatric syndrome. So there are a lot of potential causes. It takes a lot of potential forms, but it's an entity that we can conceptualize and address. Like I said, there's lots of different causes, and for that reason, interventions have to be coordinated among a lot of treaters on an interdisciplinary team. In terms of the causes, we've done some research, and for a long time, one of the prevailing theories was the overburden caregiver, because it's so difficult to take care of an elder who might be demented, agitated, combative. Sometimes they just get overwhelmed, and it leads to neglect or even physical abuse. That really has not been borne out by the literature. The caregiver burden has not been a significant predictor of elder mistreatment. Well, maybe that it's a demented elder or an elder with mental illness. No, that's possible, but it's not really seen that often. There's been another advanced theory that elder abuse is simply domestic abuse with gray hair, that it's late life domestic abuse. Either I was talking to a patient's spouse the other day, and he'd been physically aggressive with her, and I said, well, how long has this been going on? And she said, well, let's see, we've been married 62 years. So this is something that you can see that's brought to clinical attention in late life, but has been an ongoing concern. What you'll also see is that the abused spouse, when the abusing spouse becomes physically dependent on them, sometimes you'll see the shoe go on the other foot. It's not that common, and it's not a compelling predictor, but the evidence is equivocal. So what are the validated risk factors for elder abuse? What are the two identified validated risk factors by the literature? Psychiatric illness in the caregiver and substance abuse in the caregiver. Those are the two big predictors. Social isolation and financial dependence of the caregiver also seem to be compelling risk factors, although the data is equivocal. But dependent caregivers, and you'll see that, and sometimes that affects placement, because while I'm trying to place a patient in the assisted living facility, the family members really depend on that patient's benefits check, to survive and to keep that household intact. Now, is that financial exploitation? I don't know. Is it symbiosis? It's not so easy to define. And for that reason, you need a multidisciplinary approach. Okay? You need to kind of spread the burden around. And in the literature, it's referred to as a comprehensive geriatric assessment. So this is an assessment by physicians, internists, geriatricians, psychiatrists, social workers, physical therapists, speech therapists, occupational therapists, who are doing a lot of assessments on multiple functional domains. So we're talking about daily functional ability. Are they able to bathe themselves, dress themselves, drive, shop? Are they using assistive devices, hearing aids, glasses? What medications are they on? What's their nutritional status? Is their home a safe environment? Do they have advanced directives in place? Are they able to ambulate? Are they able to walk without the aid of an assistant? Are they using their walker properly? And how strong are their upper extremities? And when I was doing outpatient practice in Chicago, I told my patients, to be a successful older adult, you need really strong hip flexors and really strong rotator cuffs. You need to become quite athletic to be able to maintain daily function as an older adult. So, as I said, older age is the time of fulfillment. It's the fulfillment of life. I'm not interested in adding days to people's calendar. That's not something that I'm able to do. But I am interested in making sure that the days that they have are quality days, that they have a fruitful life for every day of their life. Okay. So that's it for this portion. Thanks for your attention, and I'll take questions, but if you could use the microphone for your individual questions and just wait till it comes to you, that would be helpful. Any questions? Here. Do we have a mic bearer? Okay.
Is it on?
Yeah, it's not for me to hear you, it's for the tape to hear you, so so speak up, please.
Yes, you said something meaningful to do was one of the great predictors. What are some suggestions there when you've got a 85 plus?
Right. That's a good question, because something meaningful to do or something to do varies depending on your functional level. So what I tell people, and I really tell my depressed patients this as much as I possibly can, because the antidepressants that we use, they benefit patients, they're often necessary, they're never sufficient in themselves. So I tell people, start doing things that make you happy, that are easy to do. I remember one of my patients was an actress, and she had had recent surgery, and she said, I just can't, my friends want me to go to this play in Chicago, and I can't sit through a whole play. And I say, just go to the first act and leave at intermission. I can't go to dinner with my friends. Just show up for appetizers and then leave. I can't make it through a whole Sunday service. Go for the first 10 minutes, pretend you're going to the bathroom, and then don't come back. Because what happens is, otherwise you get into an all or nothing proposition. It's like, I can't make it for the whole church service, so I didn't go at all. I couldn't see my friends for 3 courses, so I didn't see them at all. So you have to negotiate, the elder has to negotiate with life and say, well, I can't do this, but I can do this, okay? So you have to sort of, you are your resource now, and you have to be a good steward of your resource. But you asked about specific activities. So it's going to be dependent on what their functional status is and what their cognitive status is. If you go to the AARP website, they have a list of activities for older adults with dementia, and I actually have a few pieces of literature on it as well. What I'll say is a lot of repetitive tasks they can do very well with. People with advanced dementia can still fold clothes. We give them baby dolls on the unit sometimes, or stuffed animals for them to take care of. I had a patient who was a steam fitter, and our occupational therapist in Chicago had a wonderful set of tiny PVC pipes with connectors, and that kept him occupied for a significant amount of time. Older adults with advanced dementia can read very easily. They may not be able to tell you much about the content, but they can be at a family gathering like Thanksgiving, and they can read a Bible verse or they can read a poem and be part of the interaction and be included. There's a great video series, and you can get the DVD, but it's on public television stations. Sometimes it's called Sit and Be Fit. So it's exercises for people with limited mobility, and literally it's sitting exercises. So there are book clubs, there are social organizations, cafe clutches and things like that. So socialization is important. Walking, tours, there are a lot of activities. There's also a publication called Creative Forecasting that's used for occupational therapists and recreational therapists for people with dementia. And they have different activities. Remember when and reminiscence exercises are very common occupational therapy groups on a geriatric unit. They'll play a piece of music from 1956 and say, does anybody remember the singer, Rosemary Clooney? And does everybody remember what happened that year? Do you remember what? So those reminiscences are important. And projects, again, stuffing envelopes, volunteering, doing gardening. Some programs have raised plant beds so that people in wheelchairs or people with limited mobility can still enjoy gardening. So a lot of the activities that they've always enjoyed, they're still able to do. They just need some functional modifications. Does that answer your question? Okay.
Okay, I have the thing.
Yeah.
Okay, my question might seem a little harsh, but I'm concerned about finances. Can you hear me?
Yeah, that's not it's for the recording.
Okay.
Yeah, you're concerned about finances.
Finances. I have an 85-year-old mother, and she lives in her 10-room home, and she has a caregiver, and every single advantage, her, daily activity is shopping. She's very difficult. She's going through a lot of money. And then I have kids that they don't have insurance. They don't have health care insurance. My mother goes to the doctor as a social outlet, like 5 times a week. I'm concerned about that. And then the other thing I'm concerned about is she puts this huge burden on me when I say, Ma, eventually you might have to go to assisted living. And she says, I'm not going to do that. You have to help me end my life. What is going to be the long-term repercussions with this whole subculture utilizing so much and this younger culture that can't support them, and then they live on and on when they no longer want to live?
Right. So that's a great series of questions, and you've opened up a lot of very complex issues, and it's going to be complex for us as a culture. Because first of all, in the United States, yes, we have a youth culture. I don't know if you've noticed, but we have a youth culture. You might also have noticed that we have a culture and have had for just about forever here in this country where your value as a person is linked to your economic productivity. And that's why you don't hear me talk about a productive life in older age. You hear me talk about a fruitful life, fruitfulness as opposed to productivity. Because in the United States, it's how much you earn and what you've got, and what you've got in the refrigerator and what you've got in the garage that really defines you. That's why it's such a major life adjustment when people's economically productive role can end. Your question is, what about the practical needs and care? What about the finances? This isn't something that they teach you in medical school, by the way. You could, if you want to ask the average psychiatrist, geriatric psychiatrist about donepezil, they can answer. But what I've learned from social workers and from geriatricians is a couple of things. The broad brushstrokes are this. If you live long enough in this country, you will spend down your assets to pay for your care. Okay? You will spend down, whatever property you have is going to be liquidated and will pay for your care. Now, some people say, well, the reverse mortgage is the answer. It can be for a very limited segment of the population. Or, well, long-term care insurance is the answer. Well, but long-term care insurance is not all-inclusive. It's quite expensive. And again, it makes sense for a limited population. Some older adults live in, they move to Florida, and they're there 30 years, and then a spouse dies. And then the kids say, Mom, you're there all alone. Come back and move up to Winnetka and be with us. And Mom goes and moves up to Winnetka and moves in with the kids who are at work or at school. All of her friends in Winnetka are either dead or in Florida. Meanwhile, her friends that she made over 30 years in Florida are there. That's not a good situation for Mom. What else can you do? Some kids, and this is more prominent in the African American community in America, the children will relocate. They will find a job and move back to take care of Mom or Dad, which honestly is great. Not everybody can do that. So your question is, how do you support them financially? Eventually, what happens for the older adult is they spend down their assets to pay for their care, and then Medicaid kicks in. Now, some people can get a spendthrift trust to protect assets and still be eligible for Medicaid. But Medicaid has a 5-year look back, and they scrutinize very heavily. So usually what I tell people is get a time machine. Go back 7 years and set up a spendthrift trust. I mean, nobody plans on needing care. So talking now to a financial planner is going to be important. And figuring out, and one of the nurse practitioners I work with made her teenage sons help take care of their grandfather. That was one of their chores. And that really enriched the family tremendously. So there are challenges out there. And yes, there will be there will be voices in the culture that say, you know, like in the United Kingdom, under national health, when you turn 65, if you're a dialysis patient, you don't get dialysis anymore. So that concept is utilitarianism. It's not something I advocate for, but I'm just telling you. I think that we have to start getting very creative and very cooperative in terms of how we're going to care for our older adults. But there are options out there. I always tell people, talk to a financial planner, talk to friends who are going through the same thing. Don't ever promise a parent that you won't put them in a nursing home, because you can't necessarily keep that promise, and you weren't put on this earth to be the curator of an older adult. I always give the same spiel, and anybody who's spent 3 days with me can probably recite it chapter and verse. When you go on an airplane and the flight attendant is giving their spiel and they say, if there's a change in the cabin pressure, the masks will drop down. What do they tell you? If you're seated with someone who needs assistance, what do they tell you to do? Put the mask on yourself first, and then help the person next to you needs help. Because if you go down, they're totally unsupported. So it's not selfish. It's not wrong. You do what you need to do to keep people safe. I'm principally the advocate for safety, and to preserve quality of life and dignity. That's a long and kind of complex answer to a complex question. Was that what you needed?
The euthanasia issue, because there are so many of my mother's friends, I mean, they're the oldest of the old. They don't want to be here anymore, but it's not like they have a bottle of Seconal.
For me, as a geriatric psychiatrist, suicidality is often a symptom of depression. In older adults with a life-limiting condition, it's not the pain that makes them want to end it. It's the fear of really severe pain. That's what the literature shows. It's not the state itself. It's not the pain, it's not the illness, it's not the decline in function. It's the fear of what's coming next. So for me, as a geriatric psychiatrist, I view it as my role to help reduce the fear and treat any underlying depression which might be contributing to an elder's suicidality, rather than hand them the Seconal. That's not my role as a psychiatrist.
It's a very valid fear.
Absolutely. So how do we handle fear? We can bring to bear therapeutic interventions that can help reduce the fear. Okay? And we can support the individual. But what form the end of their life is going to take is not for me to decide, but I can advocate for supporting the individual through the lifespan. And that's what I see as my role. And again, identifying any underlying depression or anxiety that might be treatable, that can be contributing to that idea of maybe I should just end it.
Just last question, do you think eventually they don't have that choice either? Do you think eventually they will have that choice?
That I can't predict. Because that's a cultural question. That's not simply a psychiatric question or a medical question or a gerontological question. That is what the society is going to decide is right or is wrong. So I don't think anybody has the answer to that yet. But will it be brought to question in the next 10 to 15 years? Absolutely it will.
Okay.
Having been in the substance abuse field for like 37 years, my first thought when you started was, how big is denial in the normal, what's this called? The normal
As a normal
changes
psychological
in
feature.
normal aging.
Well, again, what we're finding, what neuropsychologists are finding is that those cognitive domains that do assess risk are diminished in older adults. As in children, they're not yet developed. In older adults, the process is starting to reverse, and so their capacity for denial, in that, if we want to call it that, is augmented in aging. So older adults are pretty optimistic. And if you ask an older adult, typically, and studies have borne this out, if you ask an older adult whether they would like to have more days of life left or better quality days, do you know what the adult will say as compared to family members? They want more days because they're optimistic. They're like, well, I'll get better. I'll feel this way. So I don't know if that's denial or the survival instinct or whatever it is, but typically older adults tend to be optimistic. That's why there's less depression. But we think it is a feature of cognitive aging. And so When that feature of cognitive aging meets substance use disorders, then you have a very powerful problem. When that feature of cognitive aging is brought to bear in decisions about, well, should I go to assisted living or should I stay at home? Well, it may not be such a problem. So it really depends on the individual circumstances.
Well, I'm not talking about necessarily into pathology. I'm 71, and I don't believe that I'm 71.
Right.
You know, I feel like I'm 51.
Yeah, I don't believe I'm 29.
Yeah, I know.
But no, that's what I said. You feel the same
Is
age
that optimism
inside.
or denial?
It's the human condition. I don't remember who said it. It might have been Madeline L'Engle. I actually have a slide on it. You're the same age inside. You're the same person inside. You don't know you're 71. And I'm at the age now where I look at pictures and I'm like, oh my God, what's happened? Because that's not who you feel like. I don't think that's denial. I think, again, age is in many ways an artificial and a cultural external construct. So when it happens to you, you don't notice it. And this is where and that's great most of the time. When older adults don't notice that their functional reserve has declined and that it doesn't take too much to knock them off equilibrium, that can become a problem. But in itself, it's neutral. Sometimes it's great, sometimes it's not so great. But that's a feature of aging as well.
Last month, I met a man that's 104. He can hear well, he can speak well, he has no signs of cognitive impairment. And I asked him, what is his secret? Of course, we're all going to ask that. He says, drinking 1 dark beer a day every 24 hours. Mm-hmm. He dances, he sings, and is on no medications.
Right. My godfather is 90. I've just got an invitation to his 90th birthday. He's on no medicines. So does lifestyle play a role in successful aging? Absolutely. Do genetics play a role in successful aging? Absolutely. Is it lifestyle or genetics in this guy? It's probably both. So he can tell you about dark beer all he wants, but a lot of it depends on who his parents were. A lot of it depends on genetics, okay? But it does depend on behaviors. In terms of, oh, should I drink a glass of wine a day? Well, do you like wine? So why is red wine better than white wine? There's a substance called resveratrol, which seems to, if you hear the researchers, the mice that they're feeding truckloads of resveratrol to, they're dancing and they're doing tightrope walking and these, they're shimmying all over the place. Well, that's great if you're a mouse and if you have all day to eat resveratrol. But what they're doing is extrapolating to the human population. They think that this is what's helping to reverse aging. So it's like, you mean I have to choke down a glass of wine every day? I hate wine. Well, you can find it in raisins, you can find it in cranberries, you can, So a healthy lifestyle and healthy eating, definitely anything that reduces your risk factors for heart disease and stroke, also reduce your risk factors for vascular dementia and other age-related decline. So lifestyle is important, but genetics are important as well. But don't believe, what happens is the researchers do research and they tell you exactly, this is what it says we think, and this is why we think it, and this is why we think we might be wrong as well. And then the press comes along and says, red wine is the fountain of youth. So be careful about kind of taking the ball and running with it. He's 104, that's great, genetics played a role. Yeah. Yeah. Oh, the mic.
If you have a patient who has advanced macular degeneration, do you assess their cognitive state differently? Because it's my experience that if you cannot see and you have age-related deafness, that you have more tendency to have hallucinations and symptoms of
absolutely and
delirium.
Yes, and people with glaucoma or cataracts are more likely. In psychiatry there are hallucinations, which is seeing something or hearing something that other people don't see or hear. That's not happening. But in older adults, you can often see not hallucinations, but illusions. They can look at that microphone stand and think it's a child because of a visual impairment. That's why when you're assessing cognition or for dementia screening or for delirium screening, you want to make sure that they're wearing their glasses and that their hearing aids are working. And if you can find me a hearing aid that functions in a hospital, I will eat it. Because every time I have a patient in the hospital, their hearing aids are lost or broken or the battery's dead. I don't know what it is about hospitals, but they kill hearing aids. So it can be a real challenge to keep older adults functional, even with cognitive impairment. But back to your question, there are, as a geriatric psychiatrist, I take cognitive snapshots, as it were. And my cognitive screens are kind of like taking your temperature, your blood pressure. It doesn't tell you everything, but it tells you what it tells you. If I have a patient with macular degeneration and other impairments, then I'm probably going to refer them to a neuropsychologist for a complex series of tests, including ones that don't necessarily require intact visual functioning to be able to show you what's going on cognitively. But yeah, that's something that you have to think about. Education also modulates cognitive performance. So the Folstein Mini Mental Status Exam, the MMSE, is sort of the most popular cognitive screen. And it's valid for people with an 8th grade education or better. A lot of older adults didn't make it to the 8th grade. And so because of lower education, they'll come up with a false positive for cognitive impairment. In fact, they'll look cognitively worse off than they actually are because of low education. So I use other instruments. I never use the Folstein MMSE on an older adult. I use other instruments for that reason. So you have to see, well, what's cognitive impairment and what's something else like macular degeneration or low education. You have to plan your screening accordingly. Okay. Any other questions? I know we have another whole session, but if y'all have any other questions, you can ask me now or ask me during the break. Okay? All right, thanks very much. I'll let you take a break and we'll come back to talk about substance use disorders.